spark of infection would start to ebb, and fear that a lot of lives would be lost. It was a harrowing epidemic that brought the city's vaunted healthcare system much closer to the brink of collapse than most people even now recognize. Severe acute respiratory syndrome coronavirus 2, SARS-CoV-2 or SARS-2, is the virus that causes the disease that we've come to know as COVID-19. By the time the first cases of community spread were diagnosed in late February, SARS-CoV-2 had already rooted itself in our communities. It had been here for a while, at least since January, replicating, spreading, and doubling its numbers every 2 to 3 days. Then, in March, after thousands of cases had accumulated, the virus abruptly burst into public view. The virus didn't arrive with a group of visitors from China, where it originated, or from Italy, where it established its next major foothold. Instead, it likely rode along the breath of probably hundreds of different travelers from a variety of locations, each ferrying the infection and evading the porous controls that the federal government had put in place at U.S. airports. At the time, nobody knew what was happening. Nobody knew how much virus was being carried by people who showed no outward symptoms of the disease. These were people who might never manifest any signs of illness, but were still contagious. Without the ability to test people for the virus, we had no way of detecting its spread. We certainly had no way of stopping it. This wasn't because the United States had never imagined it might fall victim to a deadly pandemic. We certainly had imagined the possibility. In some respects, we had been preparing for this moment through 3 presidential administrations, starting with George W. Bush, who warned in a 2005 speech, following the outbreak of severe acute respiratory syndrome, or SARS-1, and then avian flu, that scientists and doctors cannot tell us where or when the next pandemic will strike, or how severe it will be, but most agree, at some point, we are likely to face another pandemic. Our country has been given fair warning of this danger to our homeland and time to prepare. We had a pandemic playbook on the shelf, ran exercises simulating the threat countless times, and developed the Strategic National Stockpile to store the medical countermeasures that the top experts thought the country would need. But when the pandemic we long feared finally arrived, we weren't ready. Many of the plans and preparations turned out to be a technocratic illusion. The stockpile lacked key essentials. A lot of what it contained didn't work. It was a metaphor for our fragile response. When I worked in the federal government in public health roles, we would say that planning for medical calamities provides you with no assurance that you're prepared to deal with one. That was certainly true for COVID. The U.S. never developed a pandemic strategy that would be broadly relevant to a range of predictable and unexpected viral threats, and the country was slow to realize the ways in which the plan we had created and tried to work from, which focused almost exclusively on the risk from flu, wouldn't apply to COVID. The federal government started off in a weak position, with plans that were ill-suited to countering a coronavirus. This mismatch between the scenarios we drilled for and the reality that we faced left us unprepared. Poor execution turned it into a public health tragedy. It was an alarming state of vulnerability for a country with the world's most technologically advanced healthcare system. Owing to mistakes in how we deployed diagnostic tests for COVID, we left ourselves blind to the virus and allowed it to spread widely and largely unchecked, so we were never able to trace its early spread and contain it. Even when the shortcomings became obvious, the Centers for Disease Control and Prevention, CDC, continued to rely on its systems for monitoring and responding to influenza, insisting even into 2021 that its flu-based interventions were the right tools in the fight against COVID. We didn't pursue an approach that closely tied our efforts to track and contain the spread of SARS-CoV-2 to the characteristics of the virus. This central shortcoming explains many of the gaps in our response to the pandemic.